Okay, now I'm going to give a presentation of prion disease, just an appetizer before our lunchtime. If you have seen this kind of disease in your medical practice, congratulations. This can be a very memorable case, and I'm sure as long as you have been seeing one case in your whole life, you won't forget it. But if you haven't seen any of these kind of cases, I'm glad today I will show my case study with you guys. So let's start with some basic conceptions. The first one is, what is prion? Prion is termed as the pathogenic agent that are transmissible and able to induce abnormal folding of the specific normal cellular proteins called prion proteins that are found most abundantly in the brain. And what about the prion proteins? The normal form of the prion protein, PRPC, it is a membrane-bound protein and abundantly expressed in the human brains. And there's another isoform of this protein that is called PRPSC. The SC stands for scrappy form, and it is a kind of protein with a beta platelet sheets and appears to result from a yet uncharacterized conformation alteration. The next thing we need to know about is the human prion disease. They can be classified into these three different types. I found they are very helpful for us to memorize the different types of prion disease. The first type is sporadic prion disease. This includes SCJD, the SFI, and the VPSPR. The second type is acquired prion disease. For example, the iatrogenic CJD. This is a lesson from the last century, and Kuro, and maybe some of you guys have known the story of the Kuro, which is found among people from New Guinea, a place who practiced a form of cannibalism in which they ate the brains from the dead people as a part of the funeral ritual. And also there another kind of virus CJD, which is we commonly call mad cow disease from the bovine species. The third type is familial prion disease. For example, the genetic CJD, the GSS, and FFI. So what is the mechanism behind the prion disease? As you can see from the picture A, this is a normal structure of PRPC, and the majority of the structure, including alpha helices, which account for 43% of the protein. But if they transferred into a pathogenic one, as you can see from the picture B, it is PRPSC, and they have 43% of the beta sheets, and this can propagate to the other normal PRPC proteins around them. And this pathogenic PRPSC is protease resistant, so they can accumulate in the brain, which can cause a spongiform change of the normal brain. Then it will induce the prion disease. So now is the interesting part. I want to show you a case that I met 4 years ago in my practice. Here is a 58-year-old female presented with progressive left upper limb stiffness, bradykinesia, hypomania, and weight loss in a period of 6 months. She denied any insomnia. The physical examinations reported a left wrist overextended with swelling and pain. The left upper limb muscle strength was 4 to 5, and muscle tension was increased. Bilateral lower limbs, the deep tendon reflex was 2+. The left ankle clonus was positive, and the palmar mental test was positive bilaterally. During the initial visit, we took psychological evaluation on her, and the MMSE was 19, MoCA was 14, and Hamilton Depression Questionnaire was 5 scores, and ADL is 54. In the next 12 months, she developed bilateral arm spasm, dysphonia, and became bedridden. She also presented deterioration of dysphagia, appetite loss, and required nasal fed. However, the swelling of the wrist was relieved spontaneously after several months. 1 year after, her condition deteriorates greatly, and the ADL is only 1 score. The other cognitive and mood scales cannot be conducted on this patient. So tell me what's the diagnosis of this patient? I will jump to the answer, the Creutzfeldt-Jakob disease. So let's review the clinical features of the CJD. Here's a highlight of the CJD. They all have a long incubation time, and they have a rapid neuropsychiatric decline, and the death usually occurs within 1 year of the symptoms onset. The early signs of the patient usually shows impaired concentration, memory, and judgment, and also they can have some deficits involving higher cortical function. And classically, the most majority of the patients has the myoclonus, especially provoked by the startle. And also some patients can present cerebellum manifestations, and also signs of cortical spinal tract involvement, the extrapyramidal signs, as we can see here in our patients. And a diagnosis tool for CJD, including the dementia cognition evaluation, and also importantly, the brain MI can always give us insight if they present with a hyperintense of the signal on DWI, FLAIR, or T2 weighted images. And also sometimes the EEG can show a typical periodic shock wave complexes. If we get the CSF from the patient, we can conduct RT-QuIC or 1433 protein or tau protein or PMCA. Maybe this technique you guys never heard from the textbook, but we're going to talk it later. Another important test is genetic test to test the sequence of PRNP. And of course, the confirmations from the autopsy. So why should we give the patient a gene test? It is very interesting that there's a very specific pattern. Some of the studies has shown that the patient's presentation can be related to the codon 129 of PRNP gene. And as you can see, they're based on the 129 amino acid on this codon, and this subtypes CJD into several different types, including the first one, MM1 and MV1, the majority part. They show the classic phenotypes. The VV2 only take up like 10%, and MV2 10%, and MM2 can present with thalamic variant or cortical variant. The most real part is the VV1, which has notable progressive of the dementia and also has the early onsets of the age. So let's move back to our case study. We have the test report, the CBC, CMP, and hepatitis virus, and the whole immunology test were normal. And we had a moderate increased serum rheumatic factors, which can be a possible reason why this patient had a swollen wrist, but spontaneously recovered after several months. The genetic test report include a positive D178N mutation. That means the aspartic acid on this 178 codon was mutated to asparagine. And with this test report, we can diagnose this patient as genetic CJD. And as we said before, that the genetic CJD is a kind of familial CJD. So we ask about the patient's pedigree. And here we saw that this patient has an age of onset at 58 years old, and she lives more than 1 year. But in her maternal side, there are 2 patients diagnosed with cortical basal degeneration. We're not sure whether these patients were CJD diagnosis because we lack of the test to confirm the diagnosis, but their symptoms can be one type of CJD, and another one is diagnosed with PD at the age of 16. And let's look at the image of this patient. As we can see from the T2 flare, we have a positive signal in the caudate improvement nuclei. And for the DW image, we have a more sensitive signal, hyperintensity in both the basal ganglia and also some intensified in the frontal lobe. The next picture is the EEG of this patient. As you can see from the red arrows labeled here, we call this diffuse slow wave with frequent sharp wave, or sharp wave, a sharp slow wave complex pattern. Unfortunately, in China, it's very hard to conduct autopsy on patients. So, and at the time I saw this patient, she is still alive, so we didn't push too much on this. So here I borrowed a picture online, and they gave a clear picture of the different stages of CJD. And as you can see on the stage 6, it's pretty clear that in the cortex area, there are a lot of spongiform encephalopathy, which cause the neural atrophy of the patient. So let's talk about management. Unfortunately, as with all prion disease, this disease is universal fatal and there are no effective treatment. So what can we do for the patients? The most important part here is to give them the supportive care, including antihistamine and the pain management and the urine incontinence, nutrition management. And also the CJD can be a really detrimental insult to the whole family. So we need to give them support and education, and also provide a genetic consult to the other family members. Here are some studies conducted in the CJD area, but unfortunately, fluoxetine, the quinacrine, and doxycycline, the previous observational studies reporting survival increase from these drugs were not supported by randomized studies. Now, a possible target has been focused on the anti-size oligonucleotide therapies, a kind of genetic therapies. We can induce the ASO into the cells and to silence the expression of the pathologic proteins, but this is still in the study. For the one type of the iatrogenic CJD prevention, which is a lesson we learned from the last century, there around 500 of patients get CJD from the surgeries like corneal transplantation or dural matter transplantation, or even injection of the growth hormones. So now CDC website, there's a guideline for us to prevent the iatrogenic transmission of the CJD. If you have interest, go to this website. As I have talked about PMCA before, I would like to give a short introduction of this technique, which is conducted mostly in our lab. And it is invented by my mentor and his mentor, Soto Claudia. Using the PMCA, even there's only a minute amount of the PRPSC, it can become a seed. And after 3 rounds of seeding, incubation, and sonication, this can magnify the beta sheets of the pathogenic proteins. And after that, we can test this great amounts of the PRPSC through the Western blot. So this technique is very sensitive, and also the specificity can reach around 80 to 90%. So that is my short introduction. And this is today's presentation. Thank you all for listening. Do you have any questions?